Next up, we have Dr. Bo Ances from Washington U right here in St. Louis. So his presentation is also on neurosarcoidosis, the great mimicker. Hello.
Hi. First of all, it's a pleasure being here. I'm Bo Ances. I'm a neurologist here. I had initial charge to do neuro and looking at neurosarcoid, but you've already heard parts of that, so you're going to hear a repetition because a repetition is always important. That's what we teach our medical students. And then was more recently directed to do pulmonary, and you just heard pulmonary as well. And I am not a pulmonologist, but it is awesome to hear that a lot of the slides and a lot of things that I was going to talk about were already discussed, so I feel better in my knowledge of also pulmonary. Myself and another colleague, David Clifford, we do see patients with neurosarcoid here, and we do have a referral basis for patients that have more of the neurological complications. Both of us do see that, just as Dr. Royal had already mentioned at University of Maryland. So I wanted to make sure you knew that our services are available for those in the community. And really, I want to say thank you to all of the patients, families, and others that are here for coming today, and really it's a great honor to be presenting to you guys. So first of all, my disclosures are I don't have any drug disclosures. I'm not affiliated with them. I am supported by NIH funding that Dr. Royal and I are on a study section together with. So I have no stocks or equity in any pharmacological or pharmaceutical company. So I'll try to give you what I try to see. I do see other kinds of patients as well with different immunological disorders. So what I'm going to be talking about, sarcoidosis, because you've been hearing these terms, we've been hearing a lot, we're going to go backwards to go forwards again. I'll be concentrating on the neuro and pulmonary sarcoidosis, some of the signs and symptoms, the prevalence of these, specifically the neuro. You've been already hearing that. And what I'm going to kind of do, since I was charged on this, is kind of give you a compare and contrast kind of situations of more of the systemic versus what happens in the brain and why we need to think of what's happening in the brain and the evaluations of that, then the diagnostic tests and our treatment, and at the end, where we are going. And in particular, you heard from Dr. Royal with ACTH. There's been some ideas, and actually Dr. Royal was here. We got the privilege and pleasure of only a couple months ago, a number of our colleagues kind of meeting together to talk about neurosarcoid. There is momentum being generated, and it's really because of foundations like this that we're starting to get this back on the map. As a side note, and you'll hear me say this at the end, we need you. And one of the biggest plugs I could possibly say to you is you need to help us help you. NIH does not see this. So as I said, the government and the funding for this is very, 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 very small. I hope I put enough varies in there. People like yourselves talking, asking NIH, asking foundations, moving this stuff forward, as you heard from Dr. Royal, are going to be the only way that this is going to get traction. There's going to be new treatments. There are going to be new diagnoses. And really that kind of research. And so we really need that. And seeing this kind of turnout is very, 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 very encouraging. So sarcoidosis is a multisystem granulomatous disease. It's of unknown etiology. You already heard about the different ages that it affects and different prevalences. And then the diagnosis, as you already heard, we can find it in different organ systems. We often do that by clinical and radiographic evidence. And then we can find by biopsy. The most important thing is this non-caseating epithelioid granulomas. And so we try to find it at least in one organ, and whatever organ system that we can find it in, and that's easiest to biopsy, we try to go after. As you already heard, skin is great. Sometimes you do have to go for lung, and then when we get into the neuro realm, then it becomes a little bit tougher, and we try to make other kinds of diagnoses or ruling out other ones. So it does mimic, and that was what I was kind of trying to say. It's really a diagnosis of exclusion, as you already heard before, and so what we're trying to do is rule out everything else before we kind of make this as our final diagnosis, especially in the neuro field. Now, you heard a little bit. I have to be technical because I apologize for my research stuff, and and going back in time, I did want to go one slide on the pathophysiology of this. So we have these antigens, so things that are out in our environment, they enter the host, and then they're kind of gobbled up, and I call them, and my son's out over there, and he likes watching Pac-Man and doing these kinds, they're kind of phagocytosed, so they're kind of eaten up by these antigen-presenting cells, and these are primarily these macrophages and other kinds of cells called dendritic cells. Then these cells process this antigen, so they kind of chew it up, and then they present it to this HLA class molecules. And so why that is important is that there are certain, I don't know if this is the pointer here, but here we go. This HLA type, so there are genetic predispositions, and so if you have this, you have an increased risk of developing sarcoid. These kinds of cells are then presented to T cells, and then these, and specifically these CD4 cells. And so when you hear the word CD4, when I'm not putting on my hat here, you also hear that in diseases such as HIV. This CD4 class cell then gets turned on, and then it starts proliferating, and meaning it starts expanding and starts attacking more, and then it forms this granuloma. So again, it's an antigen, it gets reprocessed, it turns on these T cells, and then they release, and what I say to my patients is evil humors, cytokines and cytokines, and that's what that TNF alpha, and that's why we're trying to block it with different kinds of drugs. Those evil humors, they can get turned on, and then it starts to lead to a cascade. And so what you can start to see is that we have the steroids, which is this immune class that kind of just suppresses the whole immune system. And now we've already started developing new kinds of drugs that are more specific to specific phases or specific aspects of this, and that's where we're talking and we're attacking. And so you saw ACTH, you've seen infliximab, you've seen a number of different other drugs that are now starting to be mentioned. It's really because we're really learning more about the disease and where we can start to target. So in the pulmonary side, you just heard this, and Dr. Naik did a much better job than I'm ever going to be able to do. We look for, and with the x-rays, we often go for biopsies. We try to rule out additional alternatives, and it doesn't have to be just in the lung if we can find it in other places. And we kind of use this clinical radiographic as well as this histology from either lungs or other places to make a diagnosis. And as he mentioned before, one of the most important points is that about 90% of the cases have involvement of the lungs. When we start moving into the neuro side, that's where it's different. And as was mentioned before, you can have pulmonary involvement and no neuro. You can have neuro involvement and no pulmonary. And once in a while, you have pulmonary and neuro involvement as well. So the idea is that it can be a mix and match kind of game of figuring out what organ systems are really involved. In regards to neurosarcoid, there are these classifications. So there's this definitive, and that's often made by the presence of it and making it, and actually sometimes even doing biopsies, probable, and then we get into this possible. And what we do, and as a neurologist, just like Dr. Royal, what we do is we try to rule out all of these other diseases, and you heard a number of these already being mentioned. So we do a large differential. And so when some of you may have been worked up, or family friends were worked up, it's these ruling out these other diseases before we kind of come to this diagnosis of sarcoid. Now, in the nervous system itself, it's very heterogeneous. So we talked about it can be involving multiple different organ systems. Even within the brain has different manifestations. So it can affect some deep areas, the hypothalamus of our thing, so that's like our kind of temperature control. Hydrocephalus, that kind of thing we call water on the brain, so the ventricles, the water and the fluid around the brain can expand. Some patients can present with cognitive decline. Some patients, as you already saw, can have spinal cord involvement, so they have walking problems. They can have often cranial nerve involvement, so we see these nerves that control our face, especially our facial muscles and doing smile, they can be picked off. And then the most common of them is the vision, so the optic nerve. And you already heard that sometimes we need to do biopsies. And so it's not just heterogeneous in the body, it's heterogeneous even within the brain itself. And the prevalence is quite rare. It's not as common a disease, but yes, we do see it pretty often here at WashU. The idea in this slide is that we have a large amount of inflammatory disorders. And when patients come and they talk to me, one of the first questions, and we already heard this before as well, is this MS? Because it's affecting often in younger Caucasian women. Is this MS, or I've heard of that disorder, MS? And the answer is no, it's not MS, but there are other disorders. And what this paper actually did is it looked at individuals and said, what's the prevalence besides MS? So it's these CNS inflammatory diseases with other than multiple sclerosis. And the point is that neurosarcoid is very high up on that list. And so the idea is that when we start to see patients in specific age groups, we start to need to think about sarcoid if it is not MS. And so it's gaining more and more traction. My guess is that we're probably underdiagnosing it in the community. In the neurosarcoid realm, 2/3 of our patients have a monophasic illness, and as I said to you before, it's kind of those cranial nerves are usually involved, often the facial nerve, so smiling or can't move the face. Sometimes a meningitis, so you heard before fatigue, kind of a little bit of confusion, just kind of feeling under. And then there can be a relapsing course, and it can pick off multiple other nerves, as well as then also invade and affect multiple areas of the brain. And as you heard before, it not only goes for the brain, it can also go for muscle, and it can also go for nerve. And so sometimes when we have, and we've had a number of cases, as was mentioned before, you said you could hear with skin biopsies, we can do muscle biopsies and also nerve biopsies and spare instead of going for the brain, and can make diagnoses as well using those kinds of methods. And so you really need to look all over the body, and it's really, you're becoming not just a neurologist, but actually a general practitioner, because you want to make sure, are there other ways we can make a diagnosis of these individuals? You already heard about this chest X-ray staging. I'm not going to get into that. You've already also heard about PET imaging. So plug for here, as I do a lot of neuroimaging. This is a very safe procedure, can easily be done. The description you heard was absolutely right, and those are actually the words I use as well, that lighting up like a Christmas tree. You can see areas that light up that can make it very easy or amenable. And then you already heard also about TBNA and EBUS, these endobronchial ultrasound guided. The test that I would say is that I'm not a pulmonologist. These are all the things that I read. You can see differences. I will say that I think most of us don't follow the ACE as much. It's not as much of a diagnostic help for us, and can be elevated or can be suppressed, as you already heard. So it is a measure, but I usually tell my residents that that's not the measure that we'll be following in these individuals. In the neuro realm, it's like Monty Python. We are searching for that holy grail, and we have not yet found it. So in particular, as I said before, this ACE, when we can be also sent in the CSF, so in the spinal fluid of individuals, that's not really that helpful. We can do injections actually of the granuloma to help us, but that's actually not useful and is not being used as much anymore. You heard about this huge workup, and many of you may have even had some of these kinds of workups for the diagnosis. And really, the idea is, can we find an area for ruling out instead of, if we don't have to go to the brain for the diagnosis. When it does invade the brain, here's a collection from a colleague of Dr. Wells, Dr. Stern, of different kinds of cases that he's seen. We've seen similar kinds. There can be meningeal enhancement, there can be parenchymal involvement, there can be spinal cord involvement throughout. Sometimes, as you can see, these areas are where biopsies were. There can be subcortical kinds of involvement as well in the brain. So it can be all over or diffuse within the brain. And there's not one radiographic kind of like hallmark. It's really taking the diagnosis, taking what's happening to the patient, and really thinking about it to kind of enter into your consideration for sarcoid. There have been some CSF measures that we are starting to consider, and there have been a number of journal articles in somewhat small numbers, but it's starting to increase. Patients with active disease, if they do have a neurosarcoid, they often have elevated cell counts. So here are patients that have active disease versus stable, an increase there. increases in protein. And what that means is that the cell counts mean that there's active inflammation, active of those white blood cells kind of getting into the brain. Protein, that barrier between the brain and the rest of the body is now broken, so protein can get into the brain, and we can now measure that. There's a lower glucose, and then there's also measures of turnover, something we call lactate, and then we can look at how much of these immunoglobulins, or these kind of Y-shaped things that are a kind of attack and help us in our defense, and these individuals who have active have more of those. So the idea is that with active inflammation, we can kind of say, is this person having active disease? If we do a spinal tap or a lumbar puncture, that can help us. More recently, there's been this CSF soluble interleukin-2 receptor, this IL-2R, not done by all the labs. I'm going to be telling you it's a send-out lab for us, but it can be done. It has a decent sensitivity as well as specificity, meaning that how predictive it is compared to other diseases. So these are healthy controls, people who have MS and who have other variety of diseases. It's elevated in these individuals. It's not yet being commonly used, but in a number of patients, we've actually used that as an additional marker to follow an individual. Here was an individual who had it, then got steroids and had, after starting on steroids, had a decrease in these levels. Not yet ready for prime time, but is one of those measures, as you were hearing before, that you can start to follow in these individuals. Larger studies need to kind of incorporate this to see the efficacy of this marker. So we also talked about before, and you're hearing this again, but again, repetition is important, pulmonary versus neurosarcoid. So for the systemic diseases, as you heard, the 20 to 40 milligrams, and trying to err on the lighter side. Other medications can be for steroid sparing. I just listed one of them that's commonly used, methotrexate. And then for neurosarcoid, it gets into a little bit more wishy-washy areas. The idea that we do know is that aggressive treatment earlier on and could be helpful, and then we get into other kinds of agents with more progression. Should we add on, we call it adjunctive therapy, or additional kinds of therapy for these individuals. So steroids, we can start, and we do sometimes, if they're coming into the hospital, have significant disease burden or disease load, we do give IV steroids to these individuals. Then we start doing a taper on these individuals, and then follow them on a very slow taper to try to see how well they're doing. If they do have neurosarcoid and they're not responding to the steroids, then we will add on a long laundry list, and it's really which ones you feel most comfortable with, which ones you've used, and also kind of characterization. There is really nothing yet of saying which of these is superior to the other ones. Clinical trials need to be done to rule this out. Usually what you'll start seeing is anecdotal or a couple cases using each of these different kinds of medications. We're not there yet, but studies such as you just heard with ACTH need to be done to really fully evaluate the potential of these different medications. In regards to the neuro component, we often follow with the serial MRIs, and we can also follow with CSF markers as well, but MRI seems to be the more sensitive, and we give contrast, so we see how much, if there is a breakdown in the blood-brain barrier. So what I kind of end up, and I hope I'm catching it back up on time, is that there are multiple forms present. There are forms when you have the presentations. It's not only within systemically, but also within even the brain, different areas can be involved. The workup can be very complicated. You do need reliable biomarkers. In the pulmonary area, we do have algorithms that are present, and in cardiac, you've already heard. In the neuro, not yet. We're not there yet. Hopefully, if you invite us back in the future, we'll have that with different kinds of studies that are available. Imaging and CSF are very important for the neuro side, but more work needs to be done. And we often follow, at least on the neuro side, steroids, and then other kinds of adjunctive agents. In particular, for the systemic, it is plus minus on those steroids, of use, and then if they are, a low dose of steroids is used. And then my final plug for this is, where do we go next, specific for neurosarcoid? And again, what I'd say to you is that there are few of us around. You're finding half of the field with Dr. Royal and myself. and a couple others that are out there that are very interested in this disease. We need more partnerships. It's great to hear pulmonologists and cardiac who are interested in doing this. There's not a lot of funding from this from my NIH, and we're hoping that such as this foundation will help fill this void. Larger multi-center studies, because of the rarity of this, need to be done, and using kinds of scales that were being proposed, and then using new different biomarkers for the evaluation of these therapies. And so this is my group and my son out there as well. If you have any questions, sometimes we get the MRIs not right, sometimes we do. I'd be glad to take any questions. Thank you.